Hello, I'm Naveen Pemaraju, Associate Professor in the Department of Leukemia at MD Anderson in Houston, Texas. I'm joined by my colleague, Dr. Marina Konopleva, Professor in the Department of Leukemia at MD Anderson. Today we'll be discussing our panel number 1, Shifting the Treatment Paradigm, Integrating Tagraxofusp, or SL401, into the current clinical practice for patients with blastic plasmacytoid dendritic cell neoplasm, or BPDCN. And so to begin this discussion, I'd like to set the stage with talking about the historical expectation for this very rare but aggressive blood cancer. So for our viewers, BPDCN, blastic plasmacytoid dendritic cell neoplasm, is a rare, historically rare disease, but probably has a little bit more increased incidence than what was expected in the literature. Now, chemotherapy for this disease historically has been borrowed from many other diseases, including some of the aggressive leukemia and lymphomas. And so to begin, I'd like to ask Dr. Konopleva, in our experience and in the worldwide literature, it appears that most groups are borrowing from leukemia, so AML, acute myeloid leukemia, ALL, acute lymphoblastic leukemia, and even lymphoma. What's been your experience and take on some of those regimens, and give an idea of the outcomes in BPDCN?
Thank you, Naveen. As you pointed out, we have borrowed a lot from the other heme malignancies such as AML and ALL. But in our experience, the results were always inferior compared to the AML, for example, induction rates of remission. For BPDCN, AML type of regimen induces only about 50% overall response rates, which are really suboptimal. And in addition, only the younger patients can get this type of intensive chemotherapy. And as you well know, BPDCN is a disease of elderly, and the average age is over 70 years old. ALL type regimens such as hyper-CVAD generally have high response rates, around 70 to 80%, but these responses are not lasting long, and they only last long if they're followed by allogeneic stem cell transplantation, which is again reserved only for the younger population. So there's clearly unmet need for the novel therapies in this aggressive disease. Lymphoma type regimens such as CHOP, we don't have a lot of reports in the literature, but again, the activity does not appear to be very high, and therefore the novel approaches are urgently needed for this disease.
Thank you, Marina. That was really helpful. And as you pointed out, the majority of our patients with BPDCN are really in the older age group, oftentimes unfit. So outside of this, the only other experiences that we've seen are with the hypomethylator class, and these include azacitidine and decitabine, traditionally FDA approved for MDS, myelodysplastic syndrome, and older AML in different parts of the world. But again, as you mentioned, most of these, if not all, result in transient or short-lived responses. So you mentioned this urgent unmet medical need. That's what sets us up now into 2018, 2019, and beyond. With these sort of suboptimal results and older patients, a new type of therapy was needed. And based on our work and our colleague Andy Lane at Dana-Farber and other groups, we were able to lead a phase 1/2 clinical trial of a very novel agent. This is a CD123-directed toxin known as Tagraxofusp, or SL401, which represents not only the first targeted therapy for our patients with BPDCN, but interestingly and importantly, the first ever CD123-directed therapy. So this drug, a novel drug, usually comes with it some novel side effects, and we did report that in our recent major paper in the New England Journal. I wanted to see if you could take our viewers through what is your thoughts on integrating or putting that novel agent into the clinical practice. It clearly represents a standard of care, but what do you see? Do you see all patients getting it? Are there any limitations or side effects?
Well, first of all, I want to emphasize that we're all very excited about the recent FDA approval of this novel agent for BPDCN. This is a targeted therapy that is highly efficacious with a response rate of over 90% in newly diagnosed BPDCN patients, including elderly population. So this is clearly exciting, and as you mentioned, it is now a standard of care for this disease. However, as with any therapy, there are some limitations for this treatment as well. First of all, the albumin level is very important for us to be able to administer SL401. It has to meet certain criteria, and this is a hard stop for some of the patients who are sometimes malnourished and are unable to increase albumin in the short time period where we want to administer the drug. The second limitation is the side effect, which is listed on the FDA indications, such as capillary leak syndrome, which occasionally can be fatal. And it is associated with low albumin level, fluid retention, and some cardiac complications as well. So even though this is a rare side effect, it is clearly limiting use of this agent in some patients, again, with some limited cardiac function, some inefficient renal function, and so forth. So there are few patients who unfortunately will unable to receive the therapy and therefore unable to enjoy the outcomes of this treatment. And I think despite the recent approval, we still need to look for some additional novel therapies in this disease.
Wow, thank you very much, Marina. And so with that, we conclude this panel discussion, which represents really an evolving paradigm in blastic plasmacytoid ornixal neoplasm, or BPDCN, ranging from cytotoxic or conventional chemotherapies, as we discussed, to the hypomethylator class, and now into the modern era, the really true beginning of the targeted therapy era, with its attendant side effects, new toxicities, and new paradigms. And with that, I'd like to conclude on behalf of Dr. Marina Konopleva, myself, Dr. Naveen Pemaraju. Thank you for joining us, and good day.